For epilepsy, there is hope. Hey podcast listeners, Tori Robinson here for Epilepsy Sparks Insights, a podcast about epilepsy, epilepsy research, common comorbidities, and all of the fascinating science behind it. Whether you have epilepsy, are a family member, a neurologist, neuropsychiatrist, therapist, neurophysiologist, scientist, or researcher, Epilepsy Sparks Insights is designed to help you learn more about epilepsy from the other side of the table. I'm a person with epilepsy and some missing brain tissue. I hope to help bridge the unnecessary gap between patients, the public, and the aforementioned, because epilepsy research and science are cool. Last week, we had a fun, very educational chat with Professor Gavin Woodall, a neuropharmacologist from Aston University, Birmingham, UK, and Director for the Institute for Health and Neurodevelopment, whose absolute passion for epilepsy research you could hear in spades. This week, we are talking to Dr. Janine Winterbottom, an advanced nurse specialist in epilepsy at the Walton Centre NHS Foundation Trust in Liverpool, UK, all about her NIHR research into developing a preconception care pathway for women with epilepsy. In advance, for anyone who is taking anti-seizure medications during pregnancy, or for anyone who finds themselves pregnant whilst taking them, it's really important for them to remain on treatment and continue taking their medications until they have had the opportunity to discuss things with their epilepsy specialist. Now, if you're new to this channel, do make sure that you subscribe and hit that bell for notifications. This is a weekly podcast/video. Do not go anywhere. Stay with us. Dr. Janine Winterbottom, it's lovely to have you here. Janine, please tell us about yourself.
So I'm an epilepsy nurse specialist. I started in the job as a Sapphire nurse, which I probably still am. Don't really use that title much, but from Epilepsy Action's point of view, without them to start with back in the 1990s, the job wouldn't have existed and I wouldn't be where I am now, supporting women. But yes, my title is an advanced nurse specialist in epilepsy, and I'm based at the Walton Centre in Liverpool.
And so what does your role involve? Do you know what, I think perhaps I should use the plural term roles, because you do so much.
Well, I mean, only the same as other epilepsy nurses. I mean, I think every epilepsy nurse has to be sort of like multi-skilled, and so we're nurse prescribers, and so it means independently we can adjust patients' treatments and start treatments if needed, which gives us the opportunity to work in a more independent fashion. But we work in a team, and so my work at the Walton Centre is based around a team of now, over 10 epilepsy specialist consultant neurologists. Some will refer to themselves as epileptologists, others neurologists with a special interest in epilepsy, but along the way we have those specialists to work with, and I have a team of epilepsy nurses who work with me now, which obviously when you start, I started the job on my own, and then quickly within a couple of years got joined by another epilepsy nurse, and then we've had nurses leave us and move up to different parts of the country as they do, and then and obviously try to keep the team together even through COVID. Yeah, the challenges.
Yeah, I bet. And I totally, as a patient myself, I really appreciate epilepsy nurses so much. I know that not all of us, unfortunately, yet have access to the care from an epilepsy nurse. And well, you are totally like sorting that out for us and contributing to, more people becoming involved, which is great, because they're as wonderful as our neurologist or epileptologist might be, there's only a limited time, right, that we can spend with them, and often it's about drugs and not a lot else.
And I think that's the bit about working as a team, is that if you see yourself as complementing your neurology colleagues, and they see you as contributing to that patient's experience and the journey through the living with epilepsy, and I think it's bringing the two together really as complementary. I don't think any of us can work in a silo of and I think that's often what happens in medicine, is that it becomes quite you've got these silos of expertise, and we have to spread out. So our model of care is classed as a hub and spoke, and so we are a specialist centre in the northwest, and so we take in referrals from across the country as a tertiary referral centre, but we also have our own local people that come in and join into our service, and as epilepsy nurses, look at preconception counselling is my area of sort of like special interest, but we look at people from new diagnosis, transition, all the way up to living with it many years, becoming refractory, having surgery, having vagal nerve stimulator, and so we look after people with learning disability right the way through. So we have an inclusive review of patients, so we don't only focus on individuals in one area or another. We will look at them throughout the whole life and include everyone and anyone and everyone who has epilepsy can come into our service.
Is it adults that you're with, or
Yeah.
is it children too?
Yeah, I mean,
Okay.
I started off with working with children before I got the job at the Walton Centre, but I moved to work with adults because there wasn't a job at the time for working with with children with epilepsy. I think Bernie in Birmingham, working with Pete Whitehouse, I think it is, was the only paediatric nurse, and Anne Sweeney, I should say, at Alder Hay, were the only paediatric nurses that I knew of, and there were no Sapphire nurses jobs coming in children's epilepsy at the time. So I'm talking about back in 1995 when I joined the Walton Centre. But before then I'd worked on the community working with children with disabilities, and had a population in my caseload of young children and families working with young people with epilepsy, and that's really where my interest first started, really.
Could you just confirm for us, what is a Sapphire nurse, please?
Yeah, so Sapphire was a scheme that was set up by back then it would have been the British Epilepsy Association before they rebranded and renamed themselves. But it was set up there as an anniversary of their own organisation, but also as they wanted really to look at how, like, a Macmillan nurse is so synonymous with cancer care. And anyone who says that word knows immediately what that person is. And they wanted somebody almost a name to be representative of an epilepsy nurse. Now, I think the problems that we had when the scheme got going, I was the fifth in the UK at the time.
Wow.
So they'd only started, I think, earlier or later the previous year, but certainly in 95 I started. And then some of the nurses have moved on out of the jobs now. Others have stayed, like myself, long standing. But I think where the scheme went was that we were then working within the NHS. NHS had to pick up your contract. It really jump-started the job. So it was an opportunity for a trust to take on the support of a voluntary organisation who'd done all of that voluntary funding to get the job up and running, and they'd come from a background of only having a really small number of epilepsy nurses funded directly by the trusts. So Doncaster were the first to start it up, Sheffield I think followed, and the first Sapphire nurse was placed in Hull. I think it was Karen Evans, I think, was the very first nurse to come in at that point. I'm hopeless with names, so I might have got her name wrong, hopefully not. But yes,
welcome to my world.
I know, yeah.
Why did you specialise in epilepsy? What drew you to that? Because I know that obviously there are many different types of specialist nursing.
Yeah, I mean, I think when I was working on the community, I had families who, from very small children who, I think there was some absolutely gorgeous children and their families, and so I remember one who started to have infantile spasms, and it was just so devastating for the family. And I did see it from the point of view as I was a young mum myself at that point. My child was growing up. I mean, I think I had my child when just before I went into my nursing career, so I was working in the community at that point, where I was seeing children who were either just younger than my son or older than my son, and it meant it was so real in that, as well, going into people's homes, you were with them, you were in their lives, and so some families, you were visiting them every week or sometimes even multiple times a week when the children were going through really difficult times. What got me at that point was, I find this really interesting. I want to learn more about why these children are suffering in this way. I also saw the injustices and the challenges they fought that were different than just children with disability or children with intellectual disability. It was that extra, I mean, we use this word burden, don't we, with epilepsy so often. I think it's, it's a difficult word to deal with, but I think it does explain sometimes that extra that epilepsy adds to somebody's life that people can't see, and unless you are really there, sometimes you just don't understand it. And I got that feeling really quite early on, and so my caseload as a community nurse began to add an extra child. So we used to go to our intake meeting every Monday morning, and we get the new children that were being brought, that had either had a diagnosis, or for some children even being born already with disabilities, and so they were coming into our team. As nurses, we wouldn't tend to get so involved so early on, but occasionally there were tiny babies that we get involved with, and then you're working with the family, and again you're expecting that you're going to work with them for quite a number of years. And that's what I'd spent my time doing. And over that time, I went off to the National Epilepsy Society and did their nursing qualification that they were running at the time, and just began to, really, go around and spend some time. And the job came up at the Walton Centre, and it was at a point where I'd felt I'd maybe gone as far as I could do in the community, and there was no hope my trust at the time was ever going to, or this is what they said, they were ever going to employ a nurse to work just with the field, in epilepsy. And so it was like, okay, I've got a decision to make here, and so and the job came up at the Walton, and to surprise me, they offered it me. I know, because I was working with children at the time, not adults. And my specialty is also, my nursing career is also from learning disability, not in general medicine. And so I went away, and then obviously I've got, clinical masters in general nursing, and so got my expertise, my sort of like theoretical knowledge as well to support the job, the job that I'm doing now. But yes, it all, it mushroomed from there, shall we say, because it got me working with Professor Chadwick in Liverpool, and obviously he was an oracle of information around epilepsy, and he supported me in my learning, and and he really, I suppose the rest is history, you could say, really, from that point. Yeah.
Well, you referred to him as an oracle, but I really do think the same can be said for yourself and other epilepsy nurses. And the quality neurologists, epileptologists that I've spoken to would say exactly the same thing. I think their roles are not made easier, but it's like an extra load, I think, that you take on. And it's just invaluable. Us lot with epilepsy and families shouldn't have to go, okay, well, see a neurologist, see a epilepsy nurse, and okay, who can help me with my mental health? Shall I ask for a referral to a neuropsychiatrist? All that stuff is so stressful and shouldn't be necessary. And I think that you've taken a real sort of taken some of that burden away from us, a significant amount. And on behalf of all of us, I am so grateful. I really want to. Yeah, hopefully I don't make you done it, but thank you.
Yes, I can't take it on my own for sure. Yeah, I mean, I think that's
but
it.
For all of you guys.
Yeah, we work as a team. We work as a team within our trust, and we work, and I suppose epilepsy nurses across the country now take on slightly different roles dependent on the job that they're doing, the population that they're looking after. And I think that's, I suppose it's that ability to be adaptive to who you're supporting. And so, we've got a number of neurologists, so I don't need to take on some of those roles necessarily in diagnosing, although I might question a diagnosis that's in front of me that's been made by somebody else. And so there are always that critical role that we can play for somebody. We can ask those questions that sometimes are a bit awkward, and so our patients might say to us, I'm having this problem, or I don't know whether I can ask, is that the right thing that I should be asking the consultant? It's like, okay, I'll ask it, doesn't matter, or I'll write to a GP and I'll say to a patient, don't worry, if you can't get those words out yourself because it's a bit of a problem. So as you said, mental health is quite a common one where we don't want to admit that we're not doing very well. And so we say, well, it's okay, I'll say it for you in my letter. I'll tell them that you're having problems, and you can say, well, Janine told me to speak to you, and so it takes that little bit of read the letter and you'll know why Janine told me to come and speak to you, kind of thing. And if that is the nicest way we can get somebody that extra support that we can't provide, then that's what we'll do, really. Yeah.
Aww. Oh, you'll make me cry. Okay. So anyway,
yes.
Tell us about your studies at the moment, and your research, and the focus of that, and who you're reaching out to and what you're looking for regarding involvement.
I mean, a project for mine, it's been over many, many years, it's been preconception counselling. So I first did my thesis looking at the experiences of women preparing for pregnancy. At the time, we did a search of the literature, and we were talking before, weren't we, and saying that we hadn't really found much in the way of evidence for providing preconception care for women with epilepsy. So we've been working on why is that the case, and so there are some complexities. Many interventions, shall we say, so like a drug, an anti-seizure medication is an intervention that we have that we might take, and it helps us or it doesn't help us depending on how that works. And we can measure the outcomes of that, and that's what many studies are looking at. Many of the drug trials look at outcomes of this one intervention. Preconception care is not a single intervention, so it's not something that we can take or have and oh right, that's it, we're done and dusted. And so we're looking really at what is involved in preconception care. What is it? What is it like to get it? What do we expect to receive? And then how do we try and deliver it? And what we've conceptualized, as it were, is a pathway of care. So women start on that as they start to menstruate, not thinking that women are immediately wanting babies. And women, we appreciate, plan them in different ways. They may not use the word planning. They may not even think about their life in that way of planning. And that's something to do with what we're now trying to understand, because how we offer support. For me, my colleagues might say, well, Janine runs a preconception counselling clinic. When you want to have a baby, come and let us know, and you can have an appointment or a couple of appointments with me. But women don't always think of it that way, and we know that, and that's not because they're not doing what we're asking them to do. It's just that we don't always think of our lives in that way. And so planning doesn't always come natural to wanting a family. It comes in us in different ways. And for other women, they'd maybe not think about it in that way of, I need to come and speak to my neurologist or to come and speak to my epilepsy nurse, because that's a bit of, it's not my head. That's a bit of another part of my body. They're not really bothered. And sometimes that's the message they get, or it may just be that they have been told to come and have a chat with us. But again, life goes on. None of us lead this life where we have just one thing that we're doing. We've got that juggling of lots and lots of balls, and the ball of pregnancy, as it were, may not necessarily be in our thoughts, and we're in pregnancy before we've even thought about it, really, for some.
And I think also, even though it's about health and the health of a potential fetus child, it's, pregnancy and what does one have to do to get pregnant? And people still have this issue, I think, a lot of the time talking about naughty things, which aren't naughty, but No, sometimes I ask direct questions about women and their relationships, and sometimes it can get that feeling of, oh, sorry, am I being a little bit but if you don't ask, you don't get to learn. And sometimes you're apologizing for asking a question, but it's sort of like, well, if I don't ask it, we might have not mentioned it, but it might be something that's important. And so I'm giving you the chance to have a chat about it if you want to, and obviously not everyone wants to, and that's fine. And I think that's part of the pathway that we're trying to learn now in the research, is how do you introduce this along that life with the condition, because not everyone's thinking about a baby all of the time. We know that. It's let's be realistic about what living with epilepsy is about, and as well taking medicines, as you'd mentioned, having seizures, having a poor memory. You referenced before, Tori. I was gonna say that, having a poor memory, and like that can be an issue, obviously, for lots of people taking the anti-seizure meds, but even things like the pill, and it's just, if you just forget it that one time, you could be a little bit pregnant, and it can be unplanned. So
that's right. And I think what we look at as preconception counselling is actually now quite a bigger project than just the preparation, because I think it's something that we need to have for women, as that knowledge of really what will happen to me if I do have a pregnancy. So it's almost like that, not preconception counselling, or more of what do I do if I found myself pregnant, so that we're prepared no matter how. And that's the whole point of it, really, of the project that we're looking at. So it's inviting women with epilepsy, their family, their partner, their spouse. It could be, I've already spoken to mums of women with epilepsy, and lots of partners, as well as women themselves, all telling me their different experiences. And we're now moving into what's called a Delphi, which is a kind of research that works on agreement. So it asks us to give our opinion on what will be a whole list of options, and we're saying whether we see it as being a higher priority than something else. And those priorities, we will then look at the differences of, from women with epilepsy to their partners, to family members, to those who work in voluntary organisations, to those health professionals that we want to take part in it as well. And we'll crunch those all together and then ask people to really look at their vote again, but compare it to how other people have seen that, made a judgment on what's a priority. And at the end of it, we bring a consensus, which is a final agreement, and we'll bring a group of people representative of all of those people taking part in a consensus meeting to finally put an agreement of what that pathway of care might look like, how the preconception interventions may be delivered and provided, what they might look like. And the final bit that we're working on, which won't be finished with this project, but it's beginning in this project, is how we measure the outcome. So we're looking to develop what's called a preconception patient-reported outcome measure. And patient-reported outcome measures are that way of us knowing that something's been delivered. And it's a way of benchmarking good practice, and it's a way of knowing whether you've maybe had everything that you really should have had. So people think of patient-reported outcome measures often on a surgical model, so having a knee done, having knee surgery, and so some of that outcome might be quality of life, which we might say, well, that's going to be part of ours as well, because you've got to have quality in having your child. But from knee surgery, you measure your outcome maybe by your ability to walk without pain. And so from a preconception counselling, that's where the outcome's a bit more complicated, because it's not just, say, about getting pregnant. It might not just be having a healthy baby at the end of it. There's lots of other factors as well. And it's beginning to understand what those factors are that we can then begin to test in developing what then will be our patient-reported outcome measure.
You've just given me a thought, as speaking as a supposed woman who's had to kind of go through, at least some of this. I think a huge thing for at least some people affected is that if you have management of your fertility, or your likelihood of getting pregnant, should I say, that gives you confidence, man. Because a huge thing that loads of us struggle with is confidence when you've got epilepsy, for multiple reasons, right? And so at least to think, okay, I've been able to select my potential outcome when it comes to pregnancy, and I was going to say child rearing. Gosh, that sounds almost like it's related to agriculture, but you know what I mean. And that is great for your confidence, and then I think that contributes really just to your mental health and your overall sense of well-being. Something which people, I think, will just think as about, getting a bit pregnant. It's actually a whole lot more than that, and it enables you to plan your life a bit better too. Yeah, I mean, and I think outside of the research, obviously, I do offer preconception care. Currently now myself, and so I've been measuring my own outcomes as well as obviously hoping that people would apply it to their practices. But what we know when we're offering preconception care, and many organisations do this, but maybe not enough. And what we can understand is that there's a real variety of service across the country, and it is about building up those opportunities. But preparing for pregnancy, and as you said, preparing for that future life as a woman, whether you're a teenager just growing up and beginning to think maybe in the future I might do, I'm not really sure, I don't know whether if I do or I don't want a family, which is okay, because you're no
no different than many other young women, as well as young lads. It's about saying you can grow up and you can make these decisions as you go. But what's a priority for everyone with epilepsy is we want the best care possible for you. We want your best seizure control, because any outcome in pregnancy is always improved if we have a woman with the best possible seizure control, and ideally controlled, meaning no seizures. But if that's not possible, it's about getting the best that's possible for that woman, and that's balanced about using the safest medicine that's possible. And so again, you're looking at what are the medicines that we know the most about, that a woman might feel confident to take into those years in her future. But it's also trying to make sure that when we make decisions very young in a woman's early life as that woman maturing into somebody who might think about pregnancy in the future, is that she's on a treatment she can have confidence is okay. It's not going to need a lot of work, but if it's not okay, she knows that might need some work in the future, and that work in the future is fine. We shouldn't be frightened of it, and we just now need to make sure that when she's not wanting a family, she doesn't have one. So we shouldn't be fearful of contraception. We should see it as being part of life and part of our sexual health. And so if we're in a relationship and we're not ready for a family, it is about recognizing that. And I think sometimes that's where, like you said, we shy away from those discussions, and we shouldn't really. We should be able to have that very open conversation about, I'm not really ready right now, I don't really want to get pregnant, or even I've made a decision, I don't want to be pregnant. And it might be a permanent decision, or it might be certainly for now. It might be a for now decision. And what we need then is we need to firm up that look, if you're in a sexual relationship, let's at least make sure there's an accident there. Because if you're not ready, whether it's you just not ready, or whether your medicine might mean there's a little bit that's not quite ready for you, then at least we're not having to face that, almost that part of life where I never really was ready for this, and look, my medicine, or look at this, or I haven't really got a house, or I haven't really got what I wanted for, I wanted my life to be different, or I wanted to go around the world before I did this, all lots of different reasons that might be there in a woman's, and as we said, it's men and women together who are growing up with epilepsy. But women have this extra challenge when it comes to wanting a baby, where we have to think about it just a little bit more. And that's the bit that we want women to come and speak to us about, feel comfortable, and really no conversations off the table, because
thank you so much for saying that, because I'm just thinking there could be other things involved, like I don't know, like somebody's got HIV, or somebody's got hepatitis, or I don't know, or there could be familial pressure. Like I was actually going to ask you, what lengths are you going to reach out to people from ethnic minorities, for instance? Because if we look at research, it just tends to be, unfortunately, the vast majority of people are Caucasian, and we really want to give everybody this choice and this power.
Yeah, no, thank you for that, because that has been through the COVID pandemic and starting the research in December last year, we have relied heavily on social media for our population of women in the qualitative section of the study, and we have a need now to really ensure that the population of women taking part in this section of the study, which really is about agreeing what's important, so what really will be there in those final parts of the study, we want that representation, and so we're looking to try and reach out to women. And so I'd say anyone who listens to this who knows of women who are of the of that variety of experience, and so it's experience both socially as well as with ethnic minority, religious diversity. I think it is looking at all diversity as our population is, and yes, we are trying to reach out, and so we're looking to involve other NHS sites to identify those patients for us. So we had a few sites involved very early on, collaborating with us in the qualitative research, but we're now spreading that wider, because we've recognised that we need a lot more help to really get that in diversity, and to make sure that it's a UK-wide study, so everyone across the UK have that ability to say they've been able to take part. and if they feel strongly, and a woman who's got experience is an expert of her own experience, and that's what we see as our expertise from a patient population. And so we want every and any woman who wants to feel that they can contribute and feels that they'd like to take part to just get in contact with us. Yeah.
And I would also personally say, if you are not a woman listening, but you know a couple who could benefit from this or become empowered from this by contributing, by giving their side, and then please introduce them to this. We'll have the links to everything below the video or below the podcast, because I think sometimes, well, actually a lot of the time, things are word of mouth, right? And a lot of the time, no matter the way that we're talking, people can be very nervous to talk about certain things like this, especially pregnancy, sex.
Yeah.
So if you just know anybody who you think could be interested in this, because these are pretty cool studies anyway, so I think they should be of interest to everyone, whether you're planning on breeding or whether you have epilepsy or not. It's actually really interesting.
I think the target's really of improving your life, improving seizure control, having the best drug that suits you, that might have the fewest side effects. If that comes around in your life for having a family, then that's the bonus of it. But if it's not, we haven't got you on the safest medicine, and the best medicine for you might be our most risky medicine like valproate, then we have to be really honest. We have to be very clear. And it isn't about saying for that woman, well, that's it now, you can never have these opportunities. But we are having to be honest about saying this now will be a challenge. We have to think about this in a very different way, and it does require a lot more preparation. But it is about allowing us to do that, really. And if we work, together, the woman working with me as a professional, trying to assist her in her future life for family, then it's a team approach, and as we say, it's come and have a chat with us. And don't be frightened to ask us questions, because if we don't ask them, we worry about them, and worry's never a good thing either for our mental health or even maybe our epilepsy. And so, having things
about it.
Yeah, and so it is, so it's better to just come out and ask it, and I would hope that, we can have that feeling of, as an epilepsy nurse, and as your doctor looking after you, whoever that person is that you see as your person to go and talk to about your epilepsy, that you can go and have that conversation with them. And I know my colleagues across the country would want to see themselves in that way.
If a person does not feel comfortable for whatever reason speaking to their neurologist or their current epilepsy nurse, is there a way that they could contact you or one of your colleagues that isn't going to freak them out?
Yeah. I mean, Epilepsy, Society and Epilepsy Action have all got links into their voluntary and to their support. So they've got helplines. They'll often put people in contact with their facility for them to make contact with other people in that region. So often we'll find that the local organisations know of that person who's perhaps the right person for you to go and have a chat with. So if you really are a little bit lost and don't quite know really who the right person is to go and talk to, I'd probably say get in contact with your local epilepsy organisation. They're really in a key place, and especially the local support groups, they can feel a little bit intimidating sometimes to go to. They are for me, even going and having a chat with those people, going to those groups. But yes, but I think go in and have a chat. Again, people are not going to think anything different if you go and say, look, do you guys have an epilepsy nurse that you go and speak to? Oh, you do. Where are they based? How can I contact them? How do I get a referral into them? They're people who are there doing it, having that support, but the organisations can help you out as well. And so they'll often say, oh, within your region, this is, these are the 3 hospitals that have epilepsy nurses, or this is the 1 hospital, and you can then ask your doctor to refer you there if that's what was needed. But some GPs have open access into the epilepsy services in different regions, and so it is looking at what your own GP knows about the service, and sometimes we can be surprised. We can think that they don't know. They keep telling me, oh, I should go and see a specialist. Well, if they say that, maybe that's what you need to do. Because if you've not had the chance to see a specialist, sometimes we can surprise ourselves, and they're there helping us out and giving us extra links maybe into seeing an epilepsy nurse. So I think it start with what you've got, what you know about, and maybe go and then exploring a few other options through the voluntary organisations. And and then see what other people say.
Let's end with one sort of cool fact about you as an epilepsy nurse and and what is giving you hope for the future for people affected by epilepsy. And affected, I mean people with the diagnosis, families and society. No pressure.
Yeah. I mean, heavens. Yeah. I mean, I think what we've got to hope is that, you know, we can understand where now we are, you know, beginning to widen our services meaning in the areas of what we know perhaps will help people the most, and we're developing, you know, there's new drug therapies, there's new ways of working, and like for me, I'm not inventing a new wheel, as it were. Preconception counseling's been around a lot of years. What we're trying to do is make sure that it is more available for women across the country and across the whole of the UK, and that there's a standard there. So I would hope that the work we're doing will mean that more women can get access to the support they need as they're moving through their lives. And I think we can see that having ripple effects onto other areas of our support. And there's always work. You know, my colleagues as epilepsy nurses are doing lots of interesting research across the country, and I think, you know, there's lots of research at basic science level, and there's lots of work being done for epilepsy. And I think, you know, we've got to think that this has got to filter down through into the world that we live in, and hopefully make those differences to people's lives. You know, but I hope that we can keep that focus of, you know, reducing seizures and the burden that they have on people's lives, and I think that should always be paramount in all our work.
Janine's project is funded by the National Institute for Health Research, NIHR, under its Research for Patient Benefit Programme, grant reference number NIHR 200791, and the views expressed are those of the author and not necessarily those of the NIHR or the Department of Health and Social Care. Next week, I shall be chatting to Mona Hyland, a final year PhD student at RCSI Ireland, whose project focuses on determining the effects of cannabinoids on microRNA expression in epilepsy. Follow me on Twitter, LinkedIn or Facebook, and we'd love to hear from you if you have any thoughts about today's show. Do subscribe to our podcast and know that we are always trying to improve what we are doing here for the programme. I'm Tori Robinson. Thanks for listening.